Your back hurts, but the pain you can't explain, the pain that's keeping you up at night, isn't in your back at all. It's shooting down your leg, maybe into your foot, maybe it feels like electricity, maybe it feels like your leg is on fire, and nobody has told you why. I'm a spine surgeon. That description, the leg pain, the burning, the numbness, is what I hear in my clinic almost every single day. And in most cases, there's a very specific anatomical reason for every single symptom that patient is experiencing. The problem is that most patients are handed a diagnosis, disc herniation, sciatica, radiculopathy, without anyone explaining the mechanism, without anyone pointing to a map and saying, this is which nerve is affected, this is the territory it controls, and this is why you're feeling exactly what you're feeling. That's what this video is. This is video 2 in a 4-part series on lumbar disc herniations. If you haven't watched part 1 yet, I'll put a link in the description. It covers the anatomy and the herniation classification system that everything on this video builds on. Here's what we're covering today. First, nerve root anatomy and dermatomes, what each lumbar and sacral nerve root controls, and how to map your symptoms to a specific level of your spine. Second, the clinical examination, what your doctor is actually testing when they examine you, and what those tests tell us. Third, when you need imaging, which type and what we are looking for. And fourth, the red flag symptoms that change the entire urgency equation. This section is important. I want you to know this before we finish. I'm Dr. Omar Ramos, a spine surgeon at Twin Cities Spine Center in Minneapolis. Every week, I evaluate patients who are exactly where you are right now, in pain, confused by their imaging report, and trying to understand what's happening in their own body. What I'm going to show you is the same framework I use in clinic, the same explanation I give patients before we talk about treatment options, because the only way to make a good decision about your care is to actually understand what's wrong. Let's start with the nerve roots and dermatomes. Before we get into the map, let me give you one structural concept that makes everything else easier to understand. The nerve roots that exit your lumbar spine are not the same as the spinal cord itself. In most adults, the spinal cord ends around the L1, L2 level. I covered this in video 1. Below that, your spinal canal contains a bundle of nerve roots called the cauda equina. Those nerve roots travel down through the canal and exit at specific levels on both sides of the spine. Each nerve root exits through an opening called a foramen, one on the left, one on the right, at every lumbar level. Once it exits, the nerve root controls a specific predictable territory, a patch of skin where you feel sensation, a set of muscles that perform a specific movement, and a reflex that we can test. We call the skin territory a dermatome. The muscle territory is called a myotome, and together, this gives us a map, one that lets us predict from your symptoms alone which nerve root is being compressed. This is why the shooting pain down your leg isn't random, it's following a highway, and once you know the map, you can read the road. Let's go level by level. The L3 nerve root exits between your third and fourth lumbar vertebrae. Its sensory territory covers the anterior, front, and inner side of your thigh, extending to just above the kneecap. When L3 is compressed by a disc herniation, patients typically describe pain or numbness along the front and inner thigh. It can also cause weakness in the quadriceps, the muscle group that straightens your knee. The reflex we test at this level is the patellar reflex, the classic knee-jerk test. Upper lumbar herniations at L2-3 or L3-4 are less common than the lower levels, but they produce a very different clinical picture. Patients often describe anterior thigh pain rather than the classic posterior leg and foot symptoms of lower lumbar disease. L4 exits between L4 and L5. Its sensory territory runs down the medial inner shin and into the medial foot and big toe side of the ankle. An L4 compression typically produces pain, numbness, or tingling along the inner leg past the knee down the shin. On the motor side, L4 is involved in ankle dorsiflexion or bringing your ankle up and foot upward. In severe cases, this contributes to what we call a foot drop, the inability to adequately clear the foot when walking. The reflex associated with L4 is the patellar reflex, the knee jerk. L5 is the level I see compressed most often. It exists between L5 and S1, or most commonly herniated this level. The L5 sensory territory runs down the lateral outer aspect of the leg, across the top of the foot, the dorsum, and into the first web space between the big toe and the second toe and the great toe itself. When patients tell me their big toe feels numb, or the top of their foot feels like it's wrapped in cellophane, or they have shooting pain that goes into their big toe, that is L5 until proven otherwise. The motor function most closely associated with L5 is great toe extension, the ability to pull the big toe up. Weakness here is a reliable indicator of L5 involvement. L5 is also the primary driver of foot drop. And the L5 nerve root has no consistent, reliable deep tendon reflex associated with it, which is why the clinical exam for L5 relies more heavily on motor strength and sensory testing than on reflex assessment. S1 exits at the S1, S2 level, and our second most commonly herniated level. The S1 sensory territory runs down the posterior back aspect of the calf into the lateral outer foot, the heel and the small toe side of the foot. When patients describe shooting pain that goes down the back of the leg into the heel and outer foot, the classic sciatica description, S1 is frequently the involved root. On the motor side, S1 is critical for plantar flexion or pushing the foot downward, standing on your toes. The reflex for S1 is the Achilles reflex, the ankle jerk. A diminished or absent Achilles reflex on one side in the context of leg pain is a reliable indicator of S1 involvement. This is one of the most clinically informative reflexes in a lumbar spine exam. Now, here's something important I want you to understand. The dermatomal map I just walked you through, that's the theoretical territory or textbook territory. In real patients, there is overlap between the nerve root territories, individual anatomical variation, and the reality that more than one level can be affected simultaneously. This is exactly why the clinical examination exists, because the map gives us the hypothesis, the exam is where we can actually test it. Here's what most patients don't realize about a spine exam. Every single test we do is designed to answer a specific question. It's not random, it's not ritual. Every maneuver is testing something precise, and when you understand what we're testing, you'll understand exactly what your doctor found. Now, let's go through the physical examination. The lumbar spine neurological exam has three components that we always assess together: sensation, motor strength, and reflexes. The combination of findings across all three is what determines the clinical picture. But before we get to those, there's one provocative test that drives the entire beginning of the exam. The straight leg raise, or SLR, is the single most important provocative test for lumbar disc herniation with radiculopathy. Here's the mechanism. When you elevate a straight leg, you place tension on the sciatic nerve in the L4, L5, and S1 nerve roots. If one of those roots is already compressed and irritated by this herniation, adding tension to it reproduces the patient's radicular symptoms, the shooting, burning pain down the leg. A positive SLR is when that leg elevation, typically between 30 and 70 degrees, reproduces the patient's radicular symptoms, not just the back pain, but the radiating leg pain they came in with. The sensitivity of the SLR for lumbar disc herniations is high. It's our most sensitive test. The specificity is more modest, and what that means is that most patients with a true lumbar disc herniation will have a positive SLR, but not every positive SLR means a herniation. The crossed SLR, also called the well leg raise, is when elevating the unaffected leg reproduces pain in the symptomatic leg. This is a more specific finding. It suggests that the herniation is large enough and positioned in a way that tension in the contralateral nerve root still pulls on the affected side. When I see a positive crossed SLR, I take it seriously because it usually indicates significant pathology. For sensation testing, we test each dermatomal territory using light touch and pinprick. The question we're asking is there a patch of skin where the patient has reduced or altered sensation that corresponds to a specific nerve root level? Patients often describe this as numbness, tingling, or a feeling of deadness in a specific area. When those symptoms localize to the dermatomal territory I showed you, that's a meaningful finding. For a motor strength, we grade on a scale from 0 to 5. Full strength is a 5. At L3 and L4, we test hip flexion, knee extension, and ankle dorsiflexion. At L5, we test great toe extension, ankle dorsiflexion, and hip abduction. At S1, we test plantar flexion and toe raises. When there's a meaningful motor deficit, and I define that as 4 out of 5, or less in a specific muscle group that corresponds to the suspected level, that changes the urgency of the evaluation. For reflexes, we test the patellar reflex and the Achilles reflex bilaterally. Asymmetry, or a reflex that's diminished or absent on one side compared to the other, is a meaningful finding that supports nerve root compression at the corresponding level. I want to be clear about one thing. A single abnormal exam finding in isolation is rarely diagnostic. What builds the clinical picture is the combination: sensory loss in the dermatomal territory, motor weakness in the corresponding myotome, and a diminished reflex at the expected level. When all three point to the same nerve root and the patient's symptoms map to that same territory, that's a coherent clinical syndrome. That's when imaging confirms what the exam already suggested. One of the most common questions I get is, why did my doctor wait to order an MRI? Or the opposite, I went to urgent care with back pain and they didn't image me at all. Both of those experiences, waiting and not imaging, are often the correct clinical decision. Let me explain the framework. For most patients with new onset low back pain without significant neurologic findings, the evidence-based approach is a period of conservative care before imaging, typically 4 to 6 weeks. And here's the reason. The majority of acute lumbar disc herniations improve significantly with time and conservative management. Imaging early, before giving that process a chance to occur, yields a lot of findings that are real in MRI but may resolve on their own. And that early imaging can push patients toward interventions that weren't necessary. However, and this is critical, this 6 weeks window doesn't apply if you have a neurologic deficit, if your pain is rapidly progressing, or if you have any of the reflex symptoms I'm going to cover in the next section. Those cases move faster. Now, X-rays versus MRI. X-rays show bone. They're useful for assessing overall spinal alignment, disc space height, and bony abnormalities like fractures or significant arthritis. X-rays do not show disc herniations. X-rays do not show nerve roots, soft tissue. So when your doctor orders an X-ray first for back pain, they're looking at the structural skeleton. It's a start point, not a complete picture. MRI is the gold standard for evaluating lumbar disc herniations. It shows the disc, the herniated material, the nerve roots, the spinal canal, and the surrounding soft tissues without any radiation to the patient, as compared to CT scans. When I'm evaluating a patient for lumbar disc herniation with radiculopathy, I want a lumbar MRI without contrast in most cases. The MRI confirms which level is herniated, the type and location of the herniation, which we covered in video 1, and the degree of nerve compression. One thing I always tell patients, the MRI finding has to match the clinical picture. If the MRI shows a left-sided L4-5 herniation, but your symptoms are on the right, that herniation is not the cause of your symptoms. The imaging and examination have to tell the same story. What I'm about to cover now is the most important part of this video. These are the symptoms that, if you or someone you care about is experiencing them, change everything about the urgency of seeking care. Please pay attention to this section. Reflex symptoms. Most patients with a lumbar disc herniation experience back pain, leg pain, numbness, and tingling. These symptoms can be severe and disabling. Don't get me wrong, I'm not minimizing that, but they are not emergencies in the surgical sense. They are symptoms that require proper evaluation and management, and they have time for that process to unfold. What I'm about to describe is something different. These are the symptoms of Cauda-Equina syndrome, a condition where the bundle of nerve roots at the bottom of the spinal canal are being severely compressed. Cauda-Equina syndrome is a surgical emergency. Red flag number 1 is bladder dysfunction. This can present as urinary retention or the inability to urinate despite having the urge, or as urinary incontinence where you cannot control when you have to urinate. Retention is the more common presentation in Cauda-Equina syndrome. If you suddenly cannot urinate, or if you notice that you have no control over when you urinate, that requires emergency evaluation. The red flag number 2 is bowel dysfunction, loss of bowel control, incontinence of stool, red flag. This is less common than bladder dysfunction, but equally serious. Red flag number 3 is saddle anesthesia. This is numbness in the perineal region, the area of skin that would contact a saddle if you were sitting on one, the inner thigh, the groin, and the perineum. This is the territory of the S2, 3, and 4 nerve roots, which control the sphincters. Numbness in this region indicates those roots are being compressed. Red flag number 4 is progressive bilateral leg weakness. Weakness in both legs that is worsening, difficulty walking, difficulty controlling the legs, is a sign of significant multi-root compression. If you are experiencing any combination of these symptoms, bladder or bowel dysfunction, saddle numbness, progressive leg weakness, do not wait for a scheduled appointment. Go to an emergency room right away. Tell them you are concerned about Cauda-Equina syndrome. Tell them the symptoms that you have been experiencing, because this is a time-sensitive surgical condition. I raise this not to frighten you. The vast majority of patients with lumbar disc herniations will never experience these symptoms. I raise it because there are patients who do need to know what they're experiencing, and they need to act on it right away. Let me bring this together. Your symptoms are not random. Every nerve root that exits your lumbar spine controls a specific territory, a patch of skin, a set of muscles, a reflex. When a disc herniation compresses one of those roots, it produces a predictable pattern of symptoms that we can map to a level of a nerve. The clinical examination exists to test those patterns, to correlate your symptoms with your anatomy before we look at any imaging. And the MRI exists to confirm what the examination and the symptoms suggest, not to replace it. Most patients with lumbar disc herniation have a clear path forward with time, conservative care, and appropriate management. We'll cover that in full in the next video. But if you take one thing from what I showed you today, know the reflex symptoms. Know them for yourself and for the people around you. In video 3, I'm going to cover the natural history of lumbar disc herniations, or what actually happens to a herniation over time if you don't have surgery, and the full spectrum of non-surgical treatment options, including what the evidence actually says about each one. That's the video most patients need before they're ready to have a treatment conversation. If this series is helping you understand your diagnosis, share it with someone who needs it, and subscribe so you don't miss video 3. I'm Omar Ramos, a spine surgeon at Twin Cities Spine Center in Minneapolis. I'll see you in the next one.